Well, yeah, first of all, welcome everyone to tonight's focus group on antimicrobial resistance. Before we start, I just want to give a quick, brief overview of the rules and just one or two things that will be happening with the European Forum for Primary Care. So first off, to begin with, if you can just keep webcams and microphones off. Obviously, Tim and Peter, when they're presenting, they feel free to put their webcams on so you can see them. It's a bit more personal that way. Any questions or comments during the presentations, feel free to put them in the chat box and also use it whenever you like. It's a good way for us to keep track of questions and comments. And we also save it as well. Also, if you wish to speak or ask a question at the end of the presentation, then please switch on your microphone to indicate this. And lastly, do so, give us a brief introduction of who you are and your background, just have a good idea of who you are. In terms of the focus questions for today, they should be on your screen now. Let me know if you can't see them. So obviously, if you can bear these three in mind throughout the presentation, and Pim and Peter will come back to these questions throughout the session anyway. But this is what we're basing the session on today. In terms of working groups, the EFPC has several working groups at the moment that cover a variety of topics within primary care. So one of these groups focuses specifically on AMR. There we go, sorry. On AMR, and the main activity of which is to advise the European Medicines Agency on AMR-related topics. So the focus group discussion of today intends to feed this working group with experiences and reflections on cultural aspects of the prescription and use of antibiotics. If you want to know more about other working groups that we have going on, or if you'd like to express some interest in joining, please feel free to go on our website at the bottom there, euprimarycare.org, and let us know. What I will do as well, just coming up next week briefly, before we start, we also have a video webinar on COVID-19 and the Ljubljana Community Health Care Centre. And they put together a really nice sort of mini documentary, really nicely done actually, in English, which just documents their experiences of sort of the way they've needed to change management within the health centre, and sort of integrating person and population-centred approaches. So of course you can register again via our website to participate in that. Okay, so what I will do is hand over to our presenters, Pim or Peter. I'm not sure which of you are starting, so just let me know and I'll make you the presenters.
I think it's Pim.
Pim, excellent. Okay, there we go. Yeah, Pim, if you just share your screen, you should be able to do so now.
Where's Pim? I don't see him on the screen anymore.
Yeah, I'm sharing. It takes a while here.
There we go. Yeah, perfect.
Right. So, yeah, welcome everybody. We have two presentations tonight of each of about, let's say, 15 minutes or so, and then we hope to have some half hour or a little bit more to discuss these and the questions that Tom just showed in the beginning. So my name is Pim de Graaf. I'm involved in the European Forum for Primary Care and AMR several years, and I would like to present a little bit of background to the questions that we have tonight. About Peter, you might close your microphone. The background to the questions of tonight. So. Okay, then you'll see that we need some more training in presenting this. So the background why we are talking about AMR, I think does not need a lot of explanation, but I would like to emphasize 2 points here, and that is first of all, we have more antibiotics used for animals than for humans in general in most countries of the world. In some countries, much more. So what we are discussing about human medicine and preventing of AMR in human health, that is only part of the puzzle. Another element is that in most countries there are many more antibiotics going around and being prescribed and used in primary healthcare than in hospitals. For a number of countries this has been documented, and we talk about several times more in primary healthcare. So that makes the topic for ourselves, for primary healthcare, extremely important. Another element of the background of this focus group discussion tonight is that there are already ongoing plans in many countries in the world, in Europe, but also outside Europe, that address AMR. And WHO actually has been leading already from long ago, the early 2000s already. And what you show here in this slide is only that there is a global action plan on antimicrobial resistance agreed upon by the World Health Assembly in 2015. And there was a commitment of all the member countries of the WHO to have a national action plan by 2017. Of course, this was not really achieved. In some regions, more progress has been made than in others. Also in Europe, many countries do not yet have a completed national action plan. And I will come back in a minute to the content of what should actually a national action plan contain. The last part of the background is that because of the antibiotics going around in animal health, there is a close collaboration between WHO, the Food and Agriculture Organization, and the International Organization for Animal Health. And so it's a tripartite collaboration, in which from FAO and the Animal Health Organization, there are attempts to join human medicine and ministries of health to address the antibiotic use in animals. So what is normally in a national action plan? And that first of all, you have a roadmap for action plans, because a national action plan that engages complete government needs to have a number of steps and needs to be driven by a steward or a lead ministry. And so normally national action plans would describe that. And then, of course, you need a country situation analysis. How much do you know about AMR in a country and the use of antibiotics in a country, and many other data on the situation in the country before you can make a strategy plan and what they call a results matrix. So in Europe, all countries have started to develop these national action plans. Many countries have got them, they are being implemented. Other countries are still in the process of developing them. And so we can already see what is in many national action plans and what strategies are used. And of course, all those plans do also need a monitoring and evaluation plan. And now I come to the core of it, of the national action plans, relevant for us tonight, when we want to talk about cultural elements of the use, prescription and use of antibiotics. Because in the action, you have this standard template of the strategic objectives, and the first one is immediately already addressing the area of culture. It's improving awareness and understanding of antimicrobial resistance through communication, education, and training. And so a national action plan needs to address that. In a minute, I will dive a little bit deeper into that cultural element. A second objective is then, of course, to strengthen the knowledge and evidence-based through surveillance and research. This is about laboratories, microbiology, and the ability of countries to test to do cultures and to define the levels of antimicrobial resistance according to internationally agreed standards and frameworks. So most countries would include in the national action plans to extend laboratories, design a reference laboratory or more reference laboratories, etc. A third element is what is called IPC, so the reduced incidence of infection, infection prevention and control. A fourth one is then optimize the use of antimicrobial medicines in human and animal health. That may overlap a little bit with the first objective. Either one, they can include professionals, so the professionals who prescribe antibiotics or who dispense them, the pharmacies, but it can also include the general public or farmers who are users of antibiotics for their animals. And the last one is then investing in new medicines, diagnostics, vaccines, and other tools. For primary healthcare, the first four, I think, are the most important ones. And so I want to go through them again, and now a little bit more focused on the cultural element. So when we talk about we should improve awareness and understanding of antimicrobial resistance, first of all, you need to measure actually what do people know, what does the public know, and what do professionals know. You may be aware of the Eurobarometers, and that is a system of measuring public opinion and public knowledge on a number of subjects, and the Eurobarometer on AMR is one that has been repeated already several years. This is the last one, to my knowledge. 2 years ago it was published, and it shows that just over 4 of 10 people, respondents, are aware that antibiotics are ineffective against viruses. So this is a level of knowledge. This is not yet culture, but that will follow in later. So you need to ensure public information, do information campaigns, and institutes of public health and other institutes are doing that often, and that as part of national action plans. You talk about sustained campaigns and ambassadors, people who actually popularize this whole idea of using antibiotics in a good fashion. And you need to also to highlight successes, which maybe does not happen that much in general. There is a lot of energy and resources going into the fight against AMR, and then from time to time you have to show what it really what the results are. In primary care also it would be important to have influencers, people who influence public demand for antibiotics, and also on the professional side that needs to be done. And that is a question in how far we already use these influencers. And in some countries, the campaigns engage sports people or in general well-known people, politicians or ex-politicians. And so the question is whether in primary care also we use influencers at the local or regional or national level sufficiently. An important element of the second one, the knowledge base and the evidence based, I mentioned this is about microbiology laboratories, knowing how much antimicrobial resistance there is. That is important in general, and it is extremely important to feedback to clinicians. That feedback loop we observe in many people, in many countries, that does not really function well, especially not in primary healthcare. Hospital clinicians may receive feedback, but primary healthcare physicians very often do not receive feedback on cultures or after referral to a hospital specialist, they do not receive feedback on final diagnosis and treatment, including AMR. So, and that's also a cultural matter to provide and to insist on receiving that feedback. And it will be interesting to hear from you later on your experience with that. Well, I skip or keep short the part on the infection prevention and control. Of course, that needs to be done everywhere, and vaccinations are an essential element of that. In general, the focus, the emphasis is very much on hospital-acquired infections that unfortunately are too frequent. And in some countries, the environment is so full of antibiotics that you can only expect AMR to develop over time. But that's not something that in primary care we easily address ourselves, in my opinion. So that's why I would want to go past this part of the presentation quickly. So, and here we are then, and this is one of the core elements, I think, also in terms of culture, optimize the use of antimicrobial medicines in human and animal health. And it is about those physicians in primary care we talk about tonight, especially. It's about their prescription behavior. And we all know very well that behavior is one of the three components of knowledge, attitude, and behavior. So behavior is the final outcome, and before that you get knowledge and you get the attitude of prescribers. And I think there is a wide area of research done on the prescription behaviors of GPs and of course hospital clinicians. And it shows that the knowledge by itself is only one element that determines what they are prescribing. It is patient demand very much. It is, in general, the relationship with patients and the position you have as a GP in the system. And it's also about the attitude of your colleagues in your primary healthcare team, and the practice nurse, the practice other practice staff that may influence patient demand, that may influence the prescriber as well. So that's an area of concern. I come back to that later. So the WHO has of course provided already an online course, and if anybody would be interested in that, you can look that up, and we can send a link of that. And WHO also has proposed a few categories of antibiotics that is abbreviated as AWARE. Like one category would be the what is called access here. So the antibiotic of choice for each of the 25 most common infections, and that you should have available always. Then you have the watch category, highest priority, critically important antimicrobials, and then you have the reserve category. So that is actually a proposal of the WHO to work in that manner, and also in primary healthcare, and that would be an approach that is probably very helpful in guiding the prescription of antibiotics. So, but what is necessary for that, and you see that in this slide, is that you need to guarantee the availability of the antibiotics that you agree upon in the categories. And for each country, that may be slightly different lists of antibiotics in each category, depending on the patterns of resistance, amongst others. And I've witnessed myself that in several countries in Europe, antibiotics are not available permanently or intermittently, and it is very difficult for primary healthcare providers to work in that way, not to know whether what I prescribe and what I have learned they should prescribe, whether that indeed is available. In the EU countries, all of the EU countries have already banned over-the-counter sales without prescription. In daily practice, it is different. Still, in many countries, you can get antibiotics without prescription in pharmacies. I tried it out myself recently in a Southern European country. I went to a pharmacy under pretext of having a common cold, and I got, in 2 pharmacies, I got antibiotics without further questions. So the legal element here is established in all countries, but practice is different. You have patterns of patterns of resistance that need to be published to inform practitioners who prescribe antibiotics. And you also that would be a suggestion actually to publish the results of the measures. And as I mentioned a few minutes ago, in some countries you see already a reduction of antimicrobial resistance against certain antibiotics after a couple of years of investing in rational prescribing, etc. But those successes are not much highlighted, and it might help and convince otherwise skeptical policymakers or practitioners in this area. And again, I would say that it would be very helpful to mobilize influencers in primary healthcare. And I show here in an African setting a few nurses, and actually this is a training situation. And I show this because there are among the influencers in primary care, there are many staff that might play a bigger role, and I would be curious if any of the attendants tonight would have an experience with that, or a positive or maybe a less positive experience. I mention this because not long ago in one country in Europe, I was in a practice of a GP who had not prescribed antibiotics, and when the patient left the room and came back to the nurse showed surprise that no antibiotic was prescribed, and showed her skepticism towards this practice of the doctor. And that triggered a little bit my thinking about how much do we work in general with influencers in primary care, and in the first instance it's the staff itself. Do they know actually about AMR and about the reasons not to prescribe so much, or are they left behind in their level of knowledge? So I would be interested in hearing a little bit more from you later on. So this is the fifth one again, so I skipped that one. I rather would close now with these few thoughts in the national action plans in general, but also in many countries, and I'm not talking about my own country, the Netherlands, but I talk about many countries. I see that in terms of AMR, there is not so much attention for primary care, whereas the largest amount of antibiotics are prescribed and used in primary care. I see needs to do that. I see also opportunities in the national action plans to pay attention to this in primary care. It would be good if primary care leaders in the countries would be engaged. I talk about general primary healthcare organizations, like health centers and other instances where primary care is delivered. It's about the providers themselves, the physicians, but as I said, the nurses and other staff in the practices as well, and of course those at national level that or regional level that would be influential and could help here. And finally, I would say a message that in general I like to mention is that there is no reason for pessimism. We have sufficient examples by now that it works, that if you take the trouble to develop rational prescribing of antibiotics, then gradually the AMR levels will be reduced. So I think this is the end of it. And so, of course, I'm open to questions, but I think in terms of how we organize this focus group discussion, our colleague, Peter van der Homberg, would provide his presentation first, and then we can listen to your engaging with your questions. And before Peter starts, maybe you don't mind I add that we had a number of attendants tonight for this focus group from Africa. In the participants list of this moment, I'm not sure I see more than one or two. But so Peter's presentation is more oriented towards African context. But it's the nice thing is to see the approach towards cultural elements of prescriptions. So Peter, I think the floor is to you.
Thank you, Pim. Let me get the presentation there. All right. Welcome, everybody. This is a case report from Africa on antibiotic prescription. And happily, one of the two people who executed this study is in the audience. It's Nelson. And I still hope that Florence is coming as well. And I hope Nelson will end at the end of this presentation will be found about the activity of our project. Nelson, are you there? Can you unmute for a second?
Yes, I'm here.
Okay, great. All right, Florence is not there, eh?
I think Florence has joined in as well.
Okay, great. Welcome, Florence. Maybe you say hi as well.
Hi.
Hi. Okay, welcome. You will see yourself
Thank
on the
you.
slide.
Oh yeah, that's me.
Yeah.
And Nelson and you guys, yeah.
Well, together with these two family practice residents, we did a project in Mariakani in Kenya last year. The project was actually wider, but I will focus on what we found on antibiotic prescription, and I think it's quite important. This case shows that it is a major thing in primary care, where there are lots of gains if you would apply treatment according to the guidelines. This is the next slide. Doesn't work like that. So, okay, there it is. Here are Florence and Nelson, and they did as part of a community-oriented primary care project this study in Mariakani, in a district where there were several dispensaries.
Peter, sorry to interrupt.
The project was.
Sorry, Peter. Just quickly with the presentation, if you click full screen on it, then it's easier for everyone to see on the screen, I think.
Oh, it's not full screen. Oh, I see.
Yeah,
Yeah.
exactly. There we go.
Yeah.
Perfect. Sorry.
Well, the project is briefly like this. We choose a topic based on a problem analysis, which we did, which these two registrars did together with the two coaches, Simone Jasma and me. And we ended up choosing antibiotic prescriptions in 3 dispensaries because we thought that was the main problem where the most gain could be achieved. And this was done with focus group discussions with the community health volunteers. The registrars and even the coaches participated in the daily provision of care. And we got data from the Public Health Office of Mombasa and data on the health facility. And on the basis of this, took about 3 weeks. We designed an intervention based on the literature search, and we did interactive participatory education of the health facility staff and the community health volunteers. And after 3 months, we did a brief, Nelson will tell about it, a brief assessment of how effective our intervention was. Here you see what we actually did. You see the group discussions, you see the dispensaries, you see Nelson before a hut where we did home visits, and you see us sitting in a community health volunteer education meeting of the district. So what did we select as the main healthcare problem? Now, well, you can easily see here that the common colds are actually almost half or even more of the reasons for encounter in the clinics. People would come in droves, hundreds, where half of them just had a common cold. You see, that's quite distinct from the pneumonia, which you see a little bit further. And it's also 3 times more than the complaint of fever and malaria. So, although malaria can be more deadly, we choose for URTIs because reduction of the visits for URTIs and the knowledge about it and better prescription of antibiotics would be a great help to the very busy clinics and dispensaries. So what did the community report on common colds? Well, first of all, there was a lack of awareness in the community of the natural cause of common colds. Many rushed to the facility within 2 days after the onset of symptoms. People share medication prescribed in the health facility. There's frequent use, just like in Europe and Asia, of over-the-counter antibiotics from local pharmacies for common colds. And of course, common colds are frequent also due to poor housing conditions, no hand washing, and that all enables the spread of common colds. And interestingly, the community health volunteers, when at first had more or less the same approach and perception on common colds as the community. And what did we find on the treatment of common colds? Well, in over 5s, 100% got antibiotics. And in the under 5s, it was in November, it was a little more than, it was about 60%. In December, it was about 80% that got antibiotics for common colds. So that's considerable. And also, when you look at the antibiotics they got, it's mainly amoxicillin and cotrimoxazole, but you see that when these were out of stock or for other reasons, many other, often even less effective antibiotics, broad-spectrum antibiotics were prescribed, which is very worrisome. And when we asked the mothers what they have tried so far, they said they had tried aspirin and paracetamol and that it didn't help. There was another thing that we found out about the rise of people visiting the clinic. This was that actually the district had supplied antibiotics to the pharmacies through the Ministry of Health because they got a fund from the Global Health so that in some districts they would have universal health coverage. They would speed up that process. So every visitor of the dispensary could get antibiotics for free. And mothers were quite unhappy if they didn't get antibiotics prescribed. And the staff was aware of the fear of the mothers for pneumonia, so it's so likely to prescribe. And besides, there was quite a normal practice of polypharmacy. Cough mixture was given also, or vitamin D or corticosteroids. And home remedies like honey and lemon, which were in the guidelines of Kenya, were never advised. And staff, as well as was well aware of the guidelines for sore throats and common colds. And they even would not take antibiotics themselves for common colds. So it's an interesting sort of dichotomy, as you call it. But you start understanding this whole culture if you see these hundreds of visits a day. Then prescribing seems to be the only way to quickly get people to the pharmacy. Otherwise, you drown in the number of people visiting. If you have to explain 100 times to unhappy mothers that you don't prescribe antibiotics for this, that's pretty awful. And actually, because we participated in the clinics, we did ourselves experience what it is if you don't prescribe antibiotics. But you could explain actually the mothers. And one day we had, I think, 70 or 80 mothers sent home without an antibiotic and only one with an antibiotic. So that means that nearly 100% of the URTIs had no alarm symptoms and were all could be reassured that this was a common cold that would go away by itself. So it is possible, and it is also possible to convince the mothers. But yet, there's this high awareness of death due to pneumonia. Pneumonia is the leading cause of death. With 1.2 million people, children dying worldwide. That is more than AIDS, malaria, and TB combined. And mothers and even community health volunteers often do not recognize the severity of the pneumonia. You see here in Ethiopia this community health volunteer, and you see he has beads in his hands, and he's counting the beads to count the breathing of the child. And you can see this child is already probably dying. And you can imagine the enormous pain for the mother to see her child die in her hands because the pneumonia wasn't addressed or not recognized. I think in Ethiopia, the introduction of the community health volunteers for the early detection of pneumonia and the alarm symptoms was a big success. And this Ghebreyesus, who is now the World Health Organization top guy, he was actually promoted because he successfully boosted primary care and community health volunteers in Ethiopia and was quite successful in the reduction of mortality due to pneumonia. So we decided to do an intervention, and we studied the literature, and we tested the staff. We did a test on what they knew already, and we did a test after we had the teaching, and we interviewed on their knowledge and ideas on common cold and pneumonia. And we presented the guidelines of Kenya, which were quite good guidelines. They're perfect guidelines, no problem. And we repeated the danger signs for pneumonia and the reassuring findings for common colds. And we interviewed the staff about their own solutions, and they came up with suggestions of education on the spot and instruction of the community health volunteers. And they were appealed by the idea that there would be a reduction of common cold workload if you could enable the staff to give attention to the mothers, to tell them that they don't need it, and that would make time available for more serious patients. Here you see Florence and Nelson teaching the staff in one of the health centers. If you look at the literature, it's everywhere, this problem. There was a big article about the problems in Uganda, and they were quite similar to what we found. And we also saw that the problem is rampant in Pakistan and India and Malaysia, and then in this culture. There was a huge difference in Malaysia, for example, between the Chinese and the Malaysians, where the Chinese had more, they're richer and they're more knowledgeable about common colds, so they had less antibiotics. But even in Pakistan and India, there was a huge pressure from the mother, on the mother to come home with antibiotics. The husband would say, well, did you not get antibiotics? Why did you go? And the grandmother would be angry at the mother because she always got antibiotics. So what did the mother do? And there's very little knowledge on the nature and course of events in common colds. That's the big problem. Fear and feeling guilty not to have seeking help for the common cold. So mothers would go, they would also report that, They're worried for worsening of the symptoms. They want to get medication. They trust the doctor, and they feel guilty if they wouldn't go. Well, so everybody goes to in the morning to the health center to get what they expect to get. For the staff, it's important to get a better notion of evidence-based medicine, that the guidelines are really based on evidence, that they make sense, and that it is a good idea and serves the patient right to handle according to the guidelines. And they need tools. They need tools for reassuring mothers and to reassuring staff and each other to stick to the guidelines. Anyway, it's a worldwide problem. It's the same problem in Europe, in France, and in Italy, and Spain, and it's part of a culture. And the most difficult thing really to change is culture. You can change anything, but culture is the hard. Here are the guidelines. Well, you can imagine how they look like, but they're very, very good. Here in red are the signs of fast breathing and everything. So it's very clear, and they're quite simple. So finally, how can you change the treatment of common colds and antibiotic prescription? Well, it's going to be very difficult. But I think one of the major things we discovered also in Kenya was that the Ministry of Health and the existing healthcare bodies were not quite convinced, not really aware of the hugeness of the problem. You see, they had not the idea that the overflowing of the health centers by common colds and the enormous pressure that meant for the health professionals, that is a problem they should address. And I think also the World Health Organization, the Global Fund, didn't realize that when they opened the faucet, when they had this glut of antibiotics to the pharmacies, that they actually induced an enormous run on drugs that were unnecessary. And also, it would very much help to do coaching and supervision from the Ministry of Health and the health care authorities in the districts to have quality improvement and quality assurance programs, that there should be a reward. The best antibiotic doctor, the best antibiotic health center, there should be sort of stimulus that these things that culture is going to change. And it's not only that, you need next to that a multifaceted intervention. That means education of staff, education of the community health volunteers, and education of patients. It should be on television every day instead of advertisements, that common colds with reassuring simple symptoms is not a thing to go to the health center for. Should not get antibiotics, and is actually a burden to the health centers if these people go with the common cold. But it's difficult. Even in Holland, where there's a long time education on this, people still, if it's a common cold for a week, they say, now doctor, it's now pretty long, I'm coming. You see, so it's very difficult. But one of the things we could show was that the family medicine principles in coaching these staff in the health centers are actually quite strong and quite necessary. I think family medicine principles in primary care is actually the solution if you want to realize universal health coverage in future. You need that engine, that force that is blowing this development in the right direction. So we need investment in family medicine principles and primary health care to reach universal health coverage. But now I want to ask Nelson to come up, and because he did some research in Mombasa, if there were any results.
Thank you, Peter, and thank you for allowing me to speak in this focus group discussion. Yes, so approximately after 3 months of doing the educational intervention, we went back to again do a chart review and to assess whether the prescription behavior had actually changed. And unfortunately, we found that the trend was that there was no difference after the educational intervention, even compared to before. And it wasn't overly surprising to us. I think it's something we had expected, and also from discussions with the various stakeholders, it was quite clear from the outset that this was not an issue that would be addressed through one CME or one educational intervention. It would be an issue that would need a lot of collaboration with all stakeholders, from the mothers, from the community health volunteers, to the healthcare providers within the various facilities. Yeah, I think that's all I have to say, Peter.
Thank you very much, Nelson. That exactly. It was in fact a little disappointing, because we hoped with this small intervention that we would at least have some result, but it didn't show. And let's be honest, it was only 1 hour attention of the staff and maybe 50 minutes during a CME course of the community health volunteers. And that was just too little. So you need a massive intervention, multifaceted, to really change this behavior. So that's maybe a good start point for the discussion, Tom. But maybe ask Florence also, because she was also highly involved in this, if she has something to add to this presentation.
Thanks, Peter. But there's nothing else I need to add apart from what other than what Nelson has said. Yeah, so when we had just at the beginning of the study, when we were designing the intervention, we had been prompted by the other stakeholders from the ministry that it would require more than just one simple intervention to try and address the issue of antibiotic use in that place. So that's why we had to include other types of interventions like the focus group discussion. But still, it looks like it's maybe something that we need to find out what more there is that can be added to future interventions that can actually change their prescription or use of antibiotics in that place. Yeah.
Thank you, Florence and Nelson, for your additional comments, and very valuable. And I love this project. It was a great time, and I think it's a perfect start for the discussion, because it shows the magnitude of this problem, and also the fact that it's very rooted in primary care. That's where the major problem is, and so that you can now understand why the European Forum of Primary Care has put this in a special working group and has put it high on the agenda as something that should be taken action on. Thank you very much.
So, Tom, do you guide us through the discussion, or do you want me to look at the chat box where we have a few questions? So maybe the first one of Ozden Gokdemir, how can the intercultural competencies be added into the current training curriculum? You want to say more about this question?
Well, before we are talking about the research paper, we just said that we could change lots of things, the thought of people or the curriculums and whatever we need, but it is so hard to think about cultural pressure. So maybe intercultural competencies could be one of the facts of our curriculum. Could it be made or added into our primary care facilities or somewhere else? What do you think? The question was about this.
Yeah, so is there anybody who wants to comment on this, to reflect on this? I do know that in some countries in the medical curriculum for undergraduate students, you have a program of how to do patient interviews or consultations with the patients, where you learn actually to discuss with the patient and to try to take away objections of patients against certain clinical decisions and the decision to treat or not to treat. So you get training in how to conduct that conversation. And I think that is very helpful, because very often you are time pressed, and then when a patient says, "Can you give me an antibiotic?" you don't really know how to answer that apart from giving it, whereas you do know that you shouldn't prescribe. So yes, in some countries this is integrated in the curriculum. The effectiveness is not so. I don't know if there's any evidence for the effectiveness of that. In general, I do know that in most countries, it's very difficult to change the curriculum at all, because there are so many priorities to put in the curriculum of training, and and then this very often drops off the list. But maybe somebody else wants to comment on this question. I see that Jean-Yves is asking the gaps in the education of medical students on AMR or antimicrobial prescribing and stewardship in Europe, and how to bridge them. Well, since each country and each university is free to design its own curriculum, so there are wide differences indeed. And there is not a common approach of that in Europe as yet. So the requirements for medical training are very general, and they do not specifically include topics like AMR or antibiotic prescribing. So yes, the diversity is enormous. And I do know from a few universities and countries that AMR is mostly dealt with in one teaching session, 1 hour or 2 hours, and that is it. In some universities, it is much more expanded. But again, then we are talking about knowledge, whereas we have this cultural element that is also established by habit and by the whole context in society. And I think the example Peter gave between the difference between Chinese and Malay in the same country with the same health system shows that cultural differences, expectations towards healthcare, towards your doctor, towards your own disease are determinants also of what you ask from your doctor. Again, I keep talking as long as nobody else offers himself or herself to comment on this. So Joanna Neto, is there any study on when and how these behavioral patterns developed in time history? To understand this would make it easier to understand the cultural forces that sustain the behavioral pattern that need to change. Yeah, I would agree with that. I'm not aware of any study. If anybody is, please come forward. I do know that we have theories on how come that in Nordic countries in Europe, in general, the use of medicines is lower, and in the southern and eastern part of Europe, it's higher. But this is a theory. I'm not sure in how far you can call that proven theory or evidence-based. And but it's certainly a cultural element. That in some cultures, like my own, you only take medicines when you really cannot avoid it anymore. In other cultures, as soon as you feel ill, you want medicines to support your health or to be cured. It's a mindset, it's a culture indeed, and that certainly will have its influence on the use of antibiotics as well. Yeah.
No, it's very true that even in Holland, the north and the south of Holland differ quite a lot in the amount of antibiotics and other pills like antidepressants. Lots of people have suggested that has to do with the Catholic and the Protestants. And it may be true, but it's not really. For example, in Germany, where you also have huge, half of it is Protestant, are much more medicine oriented than Holland. And France really has a culture of believing in pills. So it is a cultural thing. It's not only connected to antibiotics. And the problem is also that if it's a culture in a country, the government is also, even the president, like Trump is taking chloroquine. If the government is not doing rational drug taking themselves, there's probably little going to change in the country on drug use. And then you may only hope that ultimately evidence-based medicine will gradually convince people that taking all these drugs is actually not going to help them a whole lot.
Yeah. Yeah, I think this part of the conversation is very interesting, but with an eye on the time. Actually, we have said that we would take an hour, but if you don't mind, and those who can afford more time, I would want to continue another 10 minutes or so to see if we can also look at questions 2 and 3 that Tom mentioned at the beginning. So the first one, we explored a bit, but this is of course not a moment that we can go very deep into it. That's about the cultural elements that enhance or inhibit proper prescription and use of antibiotics. The second question is, do nurses and other staff in primary care who do not prescribe themselves influence the prescription of antibiotics? And I would be very curious to see if any of you does have any practical experience or other information on this question.
May I add my opinion?
Yes, please.
I am Emrah from Turkey. It's a big issue, the antibiotic prescription in Turkey. Lots of people prescribe, but it takes, for me as a GP, it takes about a year or two from a mother convince her not to use antibiotic in any case, upper respiratory infection, but it needs time and it needs patience also, and the patient, the mother herself, should be convinced that she can access to primary care at the early phases of the upper respiratory tract infection. If not, they want antibiotics because it's a real and close problem that can happen. The pneumonia can happen. It's a big problem for them. So the cultural elements, I can't say that if it is different in other countries, but it's in the answer for me is in the primary care. If you have a good patient and doctor relationship, and if you can invest time and work with the patient, you can change the way they answer to the question, to the diseases and the fever or upper respiratory tract infections.
Yeah, thank you. Yeah, so you underline the time it takes. It takes a lot of time and conversation with patients or parents of patients to get this behavior change. Yeah, I think that probably most of us could confirm that. Yes. We do have a question, Jean-Yves, about the STRAMA system in Sweden. Can you explain to us what that system is and what we can learn from it, maybe?
Yes, hi. I hope you can hear me. Well, basically, it's a system that has been implemented in Sweden where it's an advisory body to the Public Health Agency that's basically do a benchmarking on antibiotic prescribings by GPs and give them feedback on their prescribing behaviors. And so this seems that it has been instrumental in reducing the AMR toll in this country. So I was wondering whether that's something that could be replicated in other countries in Europe, and whether that would be easy to do so. Thank you.
Yeah, to my knowledge, this happens in several countries, indeed. Some countries are more advanced than others. We have a few Turkish participants. To my knowledge, this is happening in Turkey as well. Could you comment on that from Turkey? Okay, maybe that was too quick. But yes, this is a way indeed for GPs to be compared with their colleagues anonymously, often or mostly, and then to understand whether you are a good prescriber or a not so good prescriber. Yeah, and I think that probably is very effective, but you need quite a sophisticated data system to be able to give that feedback in a fair and regular manner.
And also, it is not only to get feedback from your colleagues, but also from your patients too. In some places, maybe your patient is getting to have a prescribed prescription for their families or for neighbors. If you do know that, they will use for themselves, not for other people, because of the health coverage. To prescribe a drug is much more appropriate. I think the other colleagues maybe have got some problems like that. And the other part is about the COVID pandemic, for example. In Turkey, maybe my colleague Emrah would like to say something about this too. We should see our patient to make any prescriptions. If we don't, that means there will be something wrong with the laws. But now, because of the COVID pandemics, we can just prescribe their reported drugs, even if we don't see face to face.
Yeah, thank you for that contribution. So I think in different countries, it's in different stages of success and of implementation. But certainly it's one of the ways forward to help GPs understand the quality of their prescriptions. There are many factors that determine that. So in terms of the cultural factors on the doctor side or the physician side, and on the public side or the patient side, I think we need to understand better what's going on. Would there be any other comment on the question about nurses and other staff in primary care who do not prescribe themselves, but they might be in support of proper prescriptions, or even to the contrary, they might affect the quality of prescription in their own way? As the example I gave about that practice where the practice nurse actually showed her criticism of the non-prescription of antibiotics. Would anybody have any similar experience or has any information on that? So maybe that would be a topic that would need more preparation before we can have an interesting discussion on that. Maybe we should go to the last question in the few minutes we have left. Earlier we had one question on COVID-19, the use of azithromycin. More in general, I was wondering whether anybody has specific experience with pressure from patients or from anywhere on physicians to prescribe antibiotics because of the fear of having COVID, or maybe because after diagnosis of COVID. Does anybody have a clinical personal experience with this? We do know that of course, patients who are quite ill with COVID, they can get a super infection with antibiotic and need antibiotics for that. What of course is happening often is that before there is any super infection, to be on the safe side, and I would call that defensive medicine, doctors, physicians often prescribe antibiotics. And this is, as I said, to be on the safe side. And with the idea that if it doesn't work, at least it doesn't harm also. And that last point is, of course, an issue of concern. To prescribe antibiotics to be on the safe side is also in the case of COVID is a difficult thing to do.
The question was from me. I was asking it because it's a viral disease as any other one. An upper respiratory tract infection, you can say it for most of the people. It will pass like that. But it's not a problem to prescribe an antibiotic for coronavirus. But why is it a problem for influenza? Or the other 20% of coronavirus that happens every April and May. Last year also there was coronavirus, but not this one. And we call them upper respiratory tract infections. And it's shameful to prescribe antibiotics to that kind of tract infection, upper respiratory tract infections. But when it comes to the corona thing, it's okay to prescribe an antibiotic for super infection. This is interesting for me. This was interesting for me. In Turkey, it's also in guideline when the early phase of the COVID disease, the infection disease professors made the guidelines and put in azithromycin there. But also they lecture us not to prescribe antibiotics.
Yeah.
This and for the first weeks of the pandemic in Turkey, also people came. They did not. For my patients, it was not 100% corona disease, but some cough, some fatigue, and then patient also afraid of the disease. As a GPU afraid of the disease, and so you just prescribe oseltamivir and azithromycin because it's in the guideline, and nobody says that okay, it's not okay.
Yeah. Well, when it is in the guideline, you have an authority indeed. We do know, of course, that for COVID, guidelines are still changing, like the use of chloroquine. That was in the beginning, it was recommended, and now it is not anymore. So yeah, but because there was still too little great experience.
As a GP,
Sorry?
As a GP, the problem for me is that why shouldn't I afraid of superinfection 5 months ago, but I should afraid now?
Yeah. No, that's correct. That's a good question. Yeah.
So that's a problem for me. The cultural thing and the pressure from other professionals, this all combines here for me.
Yeah. The cultural part there is that you become defensive in your way of treating patients if you don't know what the risks are that you run and that the patients run, of course. Yeah, that is right. Yeah. Thank you very much for this contribution. Tom, can you bring us to the end of our focus group discussion?
Yes, thank you very much, Pim, and also Peter as well for presenting and leading the discussion there. Some really interesting thoughts have been put out as well, and of course, everything will be uploaded to the YouTube channel as well in the recording. So if you want to look back on things, also feel free to get in contact with us as well regarding everything that was discussed today. Yeah, so in terms of that, I think thank you again to everyone for attending, and also Pim and Peter once more. And yeah, I'd like to wish everyone a nice evening and the rest of the good rest of the week.
Thank you. Yep. Bye-bye.
Bye.
Okay. Bye-bye, everybody.